I'm Dr. Navendu. I'm proxying Dr. Deepak Mishra, and I'll be talking about the intraocular pressure measurement in the concept of target IOP. Raised IOP is one of the primary risk factors for glaucoma that one can treat. Normal IOP is the range from 10 to 21 millimeters of mercury. The facts are the people lose vision with glaucoma because of problems with optic nerve neuropathy, but they develop the optic neuropathy because of elevated IOP. For clinicians, the most important fact is that by controlling the pressure, we currently have the best way of preventing the blindness. According to the Advanced Glaucoma Initiation Study, reducing IOP in glaucoma patients limits disease progression and slows down the visual field loss. According to the early management glaucoma trial study, for every 1 millimeter drop in IOP, a 10% reduction in risk of glaucomatous progression was observed. Tonometry is the procedure for the measurement of IOP. IOP is the most important risk factor for the development and progression of glaucoma. It is the only factor that can be treated and modified in the management of glaucoma. Therefore, the need for accurate and reproducible measurement of IOP is of utmost importance. Clinical measurement of IOP has undergone several technical advances, from the initial digital tension measurements through indentation tonometry to applanation tonometry and now to non-contact tonometry. The current gold standard still remains to be the Goldman applanation tonometer. So this is a flowchart showing us that intraocular pressure measurement can be done by monometry or tonometry or transpalpable IOP measurement can be done. In tonometry, we have indentation, we have applanation, we have combined applanation and indentation tonometry, we have rebound tonometry, contour tonometer. In applanation, we have non-contact type and contact type. In contact, we have fixed area variable force and fixed force variable area tonometers. Just to simplify, this is tonometer is direct or indirect. Direct is by monometry. Indirect is by indentation, applanation. In applanation, we have contact, non-contact. In contact, we have Goldman and Perkins. And in non-contact, we have AFF and pulsar tonometers. We'll be talking brief about these tonometers in the subsequent slides. In indentation tonometer, plunger is there to indent the cornea. The shape of the deformation is a truncated cone, and the significant volume of intraocular fluid that is displayed, it measures the intraocular pressure. In applanation tonometry, the force only is used to flatten the cornea, and the shape of deformation is a simple flattening. Shearometer has been used age long. It has some 5 false high IOP readings, like in cases of thick cornea, very steep corneas, significant corneal pathology, irregular surface, could be because of that. In the Goldman applanation tonometer remains the gold standard in the routine ophthalmic practice. The principle is Invert Fick principle, also referred to as Markov-Fick law, in which pressure is equals to force per unit area. And this is how it looks like. There are 2 rings in this. If you just stain the eye with fluorescein, and then when you indent it, if the rings are in this fashion, that means the IOP is higher than what is been shown. So you need to move the block clockwise. If this is how it is shown, then it is a lower IOP than what it is actually reading. So you need to go anti-clockwise. And if both the inner edges of the rings they touch, then this is the actual IOP, which can be reproduced on every time. That is why it is gold standard. Others are like Perkins applanation tonometer. It is inaccurate on scarred, edematous, or irregular corneas. Readings are consistent and comparable with the Goldman applanation. It is a handheld tonometer, especially useful for infants and children who cannot sit in the slit lamp. Diagonal applanation tonometer, it is similar to the Goldman and Perkins, except that the different biprism is used. It has an electric motor that varies the force. This instrument is also portable and useful in similar situations like Perkins. This handheld tonometer weighs only 700 grams, so it is very lightweighted. In McKay-Mark tonometer, it is a new electronic applanation tonometer. It functions by applanating the cornea with a probe in the center of which it has a small 1.5 millimeter diameter plunger that senses the ocular tension. We also have the newer tonometers like non-contact tonometry, ocular response analyzer, tonopen, pneumatic thermometer, DCT, which is Pascal, dynamic contact tonometer, rebound tonometers, transpalpable tonometer, continuous IOP monitoring systems, and diaton. In NCT, it is beneficial in mass glaucoma screenings because it does not require topical anesthesia and with proper use, there is no risk of injuring the cornea. The advantages are it is useful in screening programs, operable by non-medical personnel, it is user-friendly, and no anesthesia is required. In the ocular response analyzers, which is by Richard Corporation, USA, it measures the corneal response to indentation by a rapid air pulse. It measures the corneal hysteresis, which is a measure of the viscous dampening characteristics of corneal tissue. Alternative to the gold standard, the Goldman Apparatus Tonometer. The indications for ORA is measurement of intraocular pressure and assessment of the biochemical response to the cornea as tools in the diagnosing and monitoring of patients with glaucoma, to evaluate the potential for post-surgical complications in patients who are being considered for refractive surgery, for assessing the biochemical properties of the cornea in keratoconus. TonoPen is a portable version of Mackay-Mark tonometer. IOP is recorded as a wavefront. It is useful for irregular corneas as the area of illumination is very small, and it's because it is not dependent on the optical system. It gives accurate readings over contact lens as well. In band keratopathy, it overestimates the IOP. It gives higher values in eyes with low IOP and lower values in eyes with high IOP when compared to the Goldman and Ablation tonometer. Pneumatic Thermometer is similar in principle, and recordings are similar to Mackay-Mark tonometer. It apparates cornea with a probe that is supported by a column of gas, and hence the sensing device is air pressure. It is useful for diseased corneas being non-optical, and it can be used for continuous monitoring of IOP. It is different from the air puff tonometer. Pascal is a dynamic contour tonometer. The principle is by contour matching. It is developed to eliminate errors inherent in previous tonometers, such as the effect of corneal thickness and rigidity. Commercially available by Swiss Microtechnology, the instrument is mounted on a slit lamp. The instrument measures IOP in both diastolic and systolic phase of the cardiac cycle, so it takes time. And the difference in the two is the ocular pulse amplitude. Drawbacks are it is more time consuming, doesn't seem as useful in diseased corneas or after a cornea transplantation. Read a little higher than apparition tonometer in people with thin or average thickness corneas, and the recurrent cost of disposable tip is also there. In Rebound Tonometer, these are handheld ballistic devices that measure the return bounce motion of an object impacting the cornea. The diameter of 0.9 millimeter and weight of 26.5 milligram, it is an easy to use instrument and no anesthesia is required. Hence, it is useful in children too. CCT, the center column thickness, affects readings more than in GAT. In transpalpable tonometer, it is not very commonly used. It is basically used by patients for self-tonometry. And drawback is that patients with field loss may not perceive the phosphenes that are seen in this tonometry. This is a new thing, which is continuous IOP monitoring by triggerfish. Sensing by triggerfish, which can be used for 24-hour IOP recording, including sleeping hours. The patient wears the contact lens up to 24 hours and assumes normal activities, including sleep periods. The disadvantage is very high cost right now. Diatin tonometer, it is a portable and handheld tonometer. It does not require sterilization or anesthesia. It is not affected by central corneal thickness or corneal rigidity. So apart from the normal conditions in which Goldman tonometer is the gold standard, we have certain special situations in which certain tonometers can be more useful, like in irregular corneas, pneumatic tonometer, Mackay-Mark, TonoPen, or DCT, that is Pascal, is more helpful. Over soft contact lenses, pneumatic tonometer and TonoPen is useful. In gas-filled eyes, pneumatic tonometer and TonoPen is useful. For post-LASIK status, Pascal is very useful. In children and screening programs, Perkins, NCT, or eye care Pneumometer is helpful. So now we'll be talking about the target pressure concept. What is target pressure? A target pressure should be set as a goal of long-term therapy. It should be chosen on an individual basis, weighing potential benefits and risks of treatment for each patient. The goal of the clinician while treating patients with glaucoma should be to lower the intraocular pressure to a level that is safe for that particular eye. So you need to measure this target pressure. You need to decide what should be the target pressure it is individualized. So the definition of target IOP is, it may be defined as a pressure, rather a range of intraocular pressure levels within which the progression of the glaucoma and visual field loss will be delayed or halted. Individualized target pressure according to risk profile at the time of diagnosis. Setting target IOP, the factors to be considered are IOP level at which optic nerve damage occurred, extent and rate of progression of glaucomatous damage if known by the previous records, presence of other risk factors, patient's age, expected lifespan, and the medical history of the patient. The AIOP guidelines for the target IOP are, if the patient is having glaucoma with mild damage, that is, optic cupping is there but no visual loss is there, then the reduction of 20 to 30% from baseline is safe. In glaucoma patients, in glaucoma patients with advanced damage, reduction of 40% or more from the baseline is required. In normal tension glaucoma, reduction of 30% from baseline is sufficient, while in ocular hypertension, reduction of 20% from baseline is required. This is debatable. So in an open angle glaucoma with IOP in the mid to high 20s, the target IOP range should be 14 to 17 millimeters of mercury. In advanced glaucoma, the target IOP should be less than 15 millimeters of mercury. In ocular hypertensives, whose IOP is more than 30 millimeters of mercury with no signs of optic damage, the target IOP should be less than 20 millimeters of mercury. So target IOP in clinical practice, it includes a percentage or absolute amount of pressure reduction in a predetermined IOP figure or range. The target pressure should be individualized at the diagnosis and may need adjustment during the course of disease as per the, we keep on doing the fields and all. And regarding, on the basis of that, we can change the target pressure also. How to set the target pressure in clinical practice? It should be a threshold, absolute cutoff value, percentage reduction, and formula-based values. So if the clinically how to apply this target pressure, in early glaucoma, it can be from 15 to 17 millimeters of mercury, in moderate, 12 to 15, and in severe glaucoma, 10 to 12 millimeters of mercury. So just to sum it up, if the glaucomatous damage is early, then you can have a higher target IOP. If it is advanced, then you have to keep the target IOP low. If the life expectancy is short, then higher target IOP can be managed. If it is long, then you have to think about going to a lower target IOP. If this untreated IOP is high, then you can keep the IOP on the target IOP on the higher side. But if the untreated IOP is low, then that needs to be reduced further. If the rate of progression is slow, we can have a higher target IOP, but if it is fast, then you need to tend it lower down. The stage of damage in IOP level are the most important drivers for target pressure related clinical decision making to prevent blindness. Thank you.